Well, welcome to NYEBS. This is our first day, first live case. We're all excited. We have a fantastic panel of everyone, vascular surgeons, interventional cardiology. On the panel right here, Dr. Ducasse, Dr. Genovese, Dr. Mawad, Dr. Purushottamam, and Dr. Schneider. So we'll let you proceed with the case.
Yeah, thank you very much. And first of all, thank you so much to have us again here at your conference to present here a case or two. That's a big honor and pleasure for us. And hello to everybody. My name is André Schmidt from Leipzig University Hospital, Angiology, and with me is Axel Fischer, here my partner for complex cases. And this here is a complex case. Can you see the slides?
Can we put on the slides, please? Yeah, we can see it. No, he has a disclosure slide. All right, next slide. Yes.
Okay, very good. Yeah, here our disclosures. And next, please.
Next slide. Yeah.
Yeah, so this is, as you see, 64-year-old male patient, severe claudication, actually on the left, a little bit more than on the right, very short walking capacity, low ABIs. He had an MR angio of the aorta showing a total occlusion of the distal infrarenal. And you also see he has a coronary artery disease, multiple PCIs, ejection fraction not so good, and his risk factors. Yeah, and next is this MR. And with this, yeah, you very often, you don't know how calcified this is at the end. Next, please. This is our strategy. For these, we have triple access, brachial or axillary left, and of course, both groins. We try to pass somehow interluminal if possible, often also not. And then it's the question always, kissing stents, syrup reconstruction. We'll see. And if you can switch now to the angio.
Wow.
Can you see the angio?
Yes.
Yeah, that's it here. I forgot that he is quite overweight. Therefore, it's a little hard to see something. You can see here, I think you can appreciate already this is calcified. Common iliacs are also occluded, hypergastrics open again. Yeah, here, once again, on the left side, hypergastric open, on the right side as well. That's actually quite nice. And then we try to get through. Here you can see the calcium. Would be nice to be interluminal, of course, but I don't know how your experience is, but sometimes this is really difficult, especially if you cannot really see a lot, as you can not see here. It's very difficult sometimes, really, if the patient is too, the belly is too big. But we try to, we usually first try from retrograde as far as we can get. Soft tip wires here, not a good position. Then we start from antegrade, 6 French, multipurpose guiding catheter, +5 French, overlength catheter, try to get in here. Stiff Terumo, yeah, all not so easy. Here you can see here, not very happy, but eventually then the wire here from above went further down, but probably rather around the calcium here in the left common. Here we started also to do this from right. And then usually we balloon from retrograde a little bit from both sides. And then luckily a wire from antegrade fell here into the hypergastric left. Yeah, so we changed to catheter, and from antegrade, from the arm, we did the roadmap, and then we were able here to maneuver in 018 wire here from the hypergastric here into the external. So we were, just a moment, wire comes here, and then I think goes relatively easy here down. I don't think we dissected here down to the external. Then we usually snare the catheter here. Hopefully we filmed this. You can see how the Judkins right, 6 French touches the wire. So 6 French from retrograde touches the wire from antegrade. And then we snare the wire here into the catheter. This is our usual maneuver. So not a snare. I think if you use here the arterial wall to get the wire here into the tip. That works quite nicely. Yeah. Yeah, one side through, right side more difficult. We are not yet through. So it was very hard from antegrade to break here into the common. We ballooned here from retrograde, the common, still no connection. Both different angulation here. And now we thought we still can't connect. We thought, we ballooned from antegrade down. You can see here how much, so we really needed a lot of pressure here to break that calcium in the common. And now popped open. And now we are about to take a B-back catheter from retrograde. You can see the B-back now coming from the right groin to puncture into the balloon and the common iliac. Yeah, we love this maneuver in the SFA, in iliacs, of course. You do not feel so comfortable to do this. But I think if, so low pressure here, what is it, 6.5?
6.
Now, warte mal ganz kurz, darf ich mal den, now we take the catheter higher. And so you see the C marker. It would be, of course, nice if they really could come to each other in one line, but they're a little bit in a cross, so that's actually not so nice, but what can we do? So now we try, what do you think?
Wow. So just for the audience, the B-back catheter is like a re-entry catheter we use right here. So, well, I mean, it's amazing what you've shown us doing on the left side. I'll start with my panel right here. I mean, I know it's Dr. Schneider's bread and butter bypass he was talking about in his fellowship and residency. Comments, Dr. Schneider? What would you do? I mean, it's a very interesting, very complex case.
Yeah, I think the guy has an EF of 40. He's got a lot of medical problems. I would certainly do this first. The worst that happens here is if you only can get one side open, you still can do a fem-fem bypass, which is a lot easier on somebody than an aorta-fem bypass. But I think, knowing all the tools that we have now, the chances here are increased by the fact that we have a number of tools. So, of course, we'll see that in action here.
Right. So, Dr. Schmidt, before I ask other panel stuff, can you just explain to us the B-back catheter for the audience, the basic working and functionality of it?
Okay, you can see this here. So actually 4 French catheter, it's also available 2.9 French, but we usually use 4 French. Very straight catheter, you can see a little C marker. The C marker shows you a curved needle which you can push out of the catheter, now turns to the direction of the C. Maximal length 12 millimeter of that needle, 23 gauge, and with this, it's a crossing catheter, it's a re-entry catheter, it's both. It's nicely stable, and through the needle, then you can push not only an 014 wire, but also an 018. But here you can see now, because of this curve here of the common iliac, we are not in the right position. Maybe once again back. I think it's very important to turn and turn and turn all the time, but no, we are not yet good here.
Right. Yeah,
not yet good.
It's still tough. So just for the panel, I mean, I know we believe in cart, reverse cart, trying to create planes and dissections. How comfortable are you trying that aggressive technique in the iliac? Would you be comfortable? Do you need any other modality to assess before you start ballooning? I know Dr. Schneider has done, Dr. Smith has done a lot of these cases, so it looks very easy, but how would you approach that?
I think in a very similar fashion here. I mean, you know that you're going to end up stenting. My preference would be to use a covered stent, so I'm very comfortable being relatively aggressive here. It's occluded, so despite having a rupture or a perforation or even a dissection, at one point you're ultimately going to have to use a covered stent. So this would be my technique. Similarly, I tend to prefer actually ultrasound-guided reentry, so we use a Pioneer more commonly than a B-back, but yeah, that's what we would do.
Liz, yes.
Ja,
Can I have the mic on for me?
ein ganz blöder Winkel.
Yeah, we don't like the angle here. We go somewhere else, maybe here.
One of the
Stop.
adjunctive techniques I would use in this situation is,
Here. Okay.
even though I don't have it going through access yet, is probably IVIS, just to see where the
Andersrum.
plane is, because if you're in a very deep subventitial plane,
Correct.
Ja,
I get a little
so,
bit
no?
nervous
Besser.
about a cart technique, because if you end up, creating a little bit of a channel from your true
Jetzt zeig
lumen
mal.
into that false lumen and you rupture that adventitia, then you worry about potentially a perforation
Ja.
rupture
Ja.
that you can't
Gut,
control
oder?
now because you
Halt
don't
zeigen,
have.
höher.
If you are just in a dissection plane within the lumen of that occluded artery, then I'm a lot more comfortable with it. So that's probably the only thing that I would
Nochmal
add
hier oben
in the
drehen.
aortoiliac as opposed to what I would do in the infrainguinal space.
Right. I mean, yeah, that was a good point to bring up. How would the modality like an IVUS or intravascular imaging give us, if any, help
Oder?
whatsoever
Ist der
to see
Ballon
how
kaputt? Ich glaub, der
subintimal you
Ballon.
are, and with the
Mal Ballon
safety measures right there.
ablassen.
So,
Ballon ablassen.
all right. So I think Dr. Smith is just trying to re-enter as well. So what we can do is we can start with one lecture. We'll keep you live on one side. Oh, there you crossed.
Yeah, maybe. No, didn't cross.
We got excited. We know you can do
Yeah,
it, so no
maybe
pressure.
one lecture and then, sure, no pressure. Thank you. Yeah, thank you. So, you saw it went through, but actually not with the BBAC, because, we once again ballooned from antegrade, and then, in fact, the car technique worked. So, sorry, maybe I didn't film this, but you have seen this. We ballooned a little higher, coming from the arm into the aortic plug, and then the wire through. Here you can see catheter following. And then we wanted a balloon. So from the right side, the balloon came nicely up, but you can see on the left side, right at the aortic bifurcation, we couldn't take our balloon in. 580, we tried actually a 3 millimeter balloon worked, but thereafter, again, a new 580 balloon would not go through. And then what we typically then do is, we do this in below the knee arteries, in SFAs, that we once again take our BBAC in, if we have it already on the table, and we take the needle over the wire constantly in and out and drill the needle through the calcium. So it's some kind of piercing from inside. That works very nicely. So thereafter, actually, every balloon goes in. Also here, now, actually, even our used balloon went in, and we pre-dilated here now.
hier, müssen wir mal den noch mal schieben.
So
In fact,
just for
where we are now,
right. So just for the panel, would anybody, when you're not able to get a balloon expansion, and now we have devices such as lithotripsy, it's sort of, I mean, I know this is a nice fancy way of trying to modify a calcium by getting the BBAC needle out. Would anybody switch over to an IVL therapy in this case to get that expansion, start working and delivering stuff? Eric, Dr. Dakasin?
Not sure. Such depending on the previous angio CT scan and the global amount of calcium and how you cross the lesion, how you perforate with the BBAC here, and also the first answer with the first angio after the predilatation. If it's necessary, thus we may use the IVL as a vessel prep here, but not sure in all cases. And it's quite calcified, but it's not full rocky aortoiliac bifurcation. Not sure in that case I will use the IVL. Not sure.
Right, Liz, for you, do you think IVUS at this level will change any of your next steps, or we'll still keep doing what Dr. Schmidt did, just balloon, and go?
I think it helps qualify what the type of plaque you're dealing with. If it's more of a fibrotic cap and a little bit less calcium, then you're probably not going to pull IVL in that situation. But if you're seeing a lot of calcium in the deep and superficial layer, that might gear you towards IVL.
All right, perfect. So before we start the next lecture, quick question, Dr. Schmidt. What's your next plan? What's the next step you're thinking? If you can discuss with the team right here.
So we're going to balloon little bigger, take little bigger balloons. You can see here, inframesenteric going down. We cannot see the offspring now, two big lumbers. And then on top, where the pigtail catheter is, there are two lower renal arteries. So I think this is maybe not a good case for real CERAP reconstruction. Yeah, of course, we have 19 millimeter long covered aortic stents, but I think it will be also due to the calcium very hard to bring that in. So that is probably the simple classic kissing covered stent case here.
Awesome.
Yeah.
All right. So we'll let you work on that. Let's go back and see, Dr. Schmidt, what stents, how did you size it, your thought process on it?
Yeah, so predilation was with 6. He felt it. So we decided to take an 8, low pressure. Usually we take 1 millimeter bigger, but we thought 7 in a man is just too small. So we took 8, 57 B-graft plus in, and those were of course too short to reach to the hypergastric. We took 2 more. So it's actually 4 times B-graft plus 857. And now we want to do an Angio. Nochmal bitte etwas einatmen.
Zieh mal Acrinor auf.
Und so bleiben. Nicht atmen, nicht bewegen.
Wow.
Yeah, actually
Beautiful.
looks quite nice. Yeah.
Very impressive. Any comments from the panel? Anything? Looks good. Looks beautiful.
Yeah.
Great job. Yeah. Very.
Yeah, we are quite happy.
All right. No,
Was meinen Sie?
that's amazing. I mean, I guess overall, I mean, you achieved the goal. I'm sure you're going to look at the external iliacs. I think it looks fine, but if there's an issue, I'm sure you're going to tack it up by putting some stents right there. But I think overall, you have excellent results right there. Beautiful flow. Inferior mesenteric still good. Doing great. The iliacs are fine, no perforation. So I guess it's pretty impressive. Right? Very nice. Awesome.
Yeah, we are happy.
Okay, good.